Hi, everyone. Thank you all for joining today. My name is Jesse Hayman, and I'm the Chief Growth Officer at Greenspace Health. We are a mental health technology company that helps clinics, hospitals, health systems, and individual clinicians implement measurement-based care to help enhance the quality of their services. When Greenspace was founded about 7 years ago, we learned about measurement-based care and the immense impact it could have on the quality of mental health care across North America. But what's proven in research is not necessarily easy to replicate in widespread clinical practice. Things like paper and pen assessment collection, manual report building, and no client visibility may work in research, but put a significant burden on providers and clinical leaders in practice. So to help bridge that gap between research and its mass implementation in practice, we built our measurement-based care technology to reduce the burden on providers to ensure that it is easy to implement and provides clinical value to both clinical leaders, providers, and their clients. That said, with any significant change in approach, there is a need for education. And so Greenspace decided to take a lead and ensure there are consistent opportunities for the industry to learn from the world's leading measurement-based care experts. And since we've run educational sessions with many experts like the Yale Measurement-Based Care Collaborative and Dr. David Clark, and will continue to do so moving forward. Today, I have the absolute honor of hosting the second webinar in our series with Dr. Clark, and we are so excited to have him back with us today. The questions that we'll cover in today's session were submitted by attendees during last session and during our registration for this session, many of which are very common questions that come up when we're having discussions with different types of service organizations, payers, and health systems across North America. In case you missed the last session and are interested in checking it out, we'll share a couple links in the chat now for you to explore. So please feel free to jump into those. Don't worry if you didn't attend last session, you'll still get a ton of learning out of today. I wanted, though, as a quick summary of last session, to jump into a few of Dr. Clark's research and learnings from leading the launch and continued development of NHS Talking Therapies that really stood out to me, and then we can hop into it. So at the start of the program, their goal was to see an average of 50% of people accessing care fully recovered from both anxiety and depression. At the beginning, they were well below that goal at about 38%, but because of the data being collected and learning from that data, they've been able to achieve their target of 50% and plan to improve from there. Quoting Dr. Clark from last session, if we hadn't been collecting outcome data on everyone in our services, we'd still be in that position and blissfully ignorant on what to do next. And I think that sums up the value of measurement-based care really nicely. Secondly, at Greenspace, we often talk about the 4 C's of measurement-based care. They're all necessary to get the most out of it. And we have those as consistency, customization, client visibility, and collaboration. Customization specifically refers to adjusting assessments based on the patient's needs, goals, and unique experiences. And NHS Talking Therapies data speaks directly to that. In their research, the difference in outcomes is phenomenal, with clinicians using generic measures seeing a 32% improvement in symptoms, whereas clinicians that leverage one or more unique measures saw a 58% improvement in symptoms and similar results for reliable improvement and mental health problems interfering with life. As I mentioned, one of the 4 C's we call out is successful implementation of customization to the unique challenges of that individual, and that data speaks directly to it. Lastly, Dr. Clark commented on the interplay between physical and mental health. He shared a study that was conducted on individuals with cardiovascular disease receiving therapy to treat depression through their program. The results showed that those who saw an improvement in depression symptoms had a much lower risk of cardiovascular disease or new related challenges of anywhere between 10 to 15%, depending on age. The link between mental health outcomes and both mental and physical healthcare costs really helps solidify the economic benefits of evidence-based psychological care. Before we jump into things, I have a couple pieces to share that are just housekeeping items. One, we're going to have a Q&A style discussion today with Dr. Clark, and we'll have dedicated time at the end for questions. So please include any questions that come to mind in the Q&A, not in the chat. There's a button at the bottom of your screen that says Q&A. Click on that and you can submit your questions. We'll also be using an upvoting feature. So if you see a question that comes up in the Q&A that you would like answered, please give it a thumbs up or 2 thumbs up. We'll prioritize the questions with the most upvotes. As well, there'll be a survey at the end. It will only take a couple of minutes to fill out, but it'll really help us inform future educational sessions. So if you could take a moment to fill that out, that would be amazing. So it is my honor to introduce a visionary leader who has left his mark on mental health care across the globe. Dr. Clark is a pioneer in the realm of mental health, has spearheaded the creation and implementation of NHS Talking Therapies with an unwavering dedication to the well-being of people all across the UK. Through his leadership, the UK has witnessed a complete transformation in their approach to mental health, ushering an era where client engagement, depth of objective evaluation, and iterative improvement are prioritized above whichever treatment pathway an individual is on or how many sessions of care they receive. He recognized the impact that improved services would have not only on the well-being, health, and happiness of its people, but also the economic strength of the UK. And his efforts have left us with an approach and treatment that we can all strive towards to drastically improve the wellness of our population. So please join me in celebrating and welcoming Dr. David Clark. Dr. Clark, I'd love to pass it over to you for a brief introduction, and to better understand your background and motivation, it would be great if you could share what originally piqued your interest in pursuing a career in psychology.
Oh, thank you, Jesse, and lovely to join you all. I think what originally piqued my interest was my mother was the person that everyone came to talk about their problems with. And sort of that gave me the idea that psychological therapies may be effective. We do things somewhat different from what my mother did, but it sort of got me interested, and I suppose I've stayed interested for the rest of my life.
Well, awesome. Great to hear a little bit about the origin and that your mom inspired it all. So to kick things off, I wanted for the first question to just help ensure everyone is on the same page. So I was hoping you could define measurement-based care for the group and also share why you believe it matters in clinical practice.
Sure. So measurement-based care means throughout someone's course of treatment, carefully measuring their outcomes in mental health. That means their symptoms, but also how disabled they are by their mental health problem. And using those measurements, firstly, to help inform the treatment you're giving that particular person, but also collecting them for the whole of your clinic. So together, you can sort of use the data to look at, what are the sort of groups of people we're doing really well with? What are the ones that we're finding more challenging? And then the challenging people are really the gold dust. And you can focus in on, well, what can we do differently with those people? Try it out. And if you're collecting the data on everyone, you can see whether or not it works. And our experience in the NHS Talking Therapies service, I think, as you outlined, is that if we didn't have that measurement, the outcomes we are getting would be much poorer than the ones we actually get, because we've learned so much from reflecting on the data and innovating within the services and bringing the whole team along with that innovation.
Thank you very much, Dr. Clark. I think what it highlights for me and what I hear from what you're saying is the importance of process. I think some people look at measurement-based care and see it as another traditional measurement and reporting exercise. But I think it isn't about collecting data as a collection exercise, but collecting it in order to continue iterate and to continually iterate and use it to inform care decisions, and that the value is found in the process of measurement-based care. So I think that's a fantastic piece that stands out for me. We know that most other areas of healthcare have data at their core to help guide treatment decision-making. We're starting to see a change within mental health, but for the past several decades, mental health care has not functioned like other areas of healthcare with data at its core to inform treatment decisions. And so if you look at whether it's diabetes, cancer care, heart conditions, data is at the core of treatment and monitoring. Even for more subjective illnesses, you can look at chronic pain, for instance. Routine collection and use of measures are often an important part of the monitoring process. So I'm curious if you have any thoughts on why there was such a hesitation to use measurement in mental health and what you see as the momentum behind the recent change.
Yeah, so I think the first thing is to consider who is hesitant. And our experience is it's primarily the clinicians that are hesitant. They sometimes say it's too much of a burden on patients, but when we talk to patients, they in general like the idea that people are measuring whether things are changing or not and reflecting on that. So what are the sort of fears that clinicians have? Well, I think they commonly see this as just a bureaucratic exercise, a distraction from what they're doing. And obviously, it can be used that way in management, and then it's unhelpful. But also, I think they're often afraid that the data will show that things don't look quite as good as they would like, and that may be problematic for their practice. But of course, what people discover once they get into using outcome data is firstly that it really does help your therapy. It helps guide it, that patients like it. And almost always the outcomes don't look as good as you'd like when you first collect the data. But that's really the start of a journey rather than a bad place to be at. Because, of course, once you can discover that, you can learn so much more about how you can enhance things. And so for many clinicians, I think once they really get familiar with this, they can see this is something that helps them to achieve what they got into the profession to do, which is really to help as many patients as they can.
Thank you very much, Dr. Clark. I think that's very helpful, and it's amazing to hear. And I think we've seen it in practice that once clinicians get going and see the value of measurement-based care for their clients and themselves, that they generally feel really positive about and continue to engage. It's just about getting over that initial hesitation that some may have in getting started. Obviously, you've seen, I think this is a related question, you've seen tremendous success with NHS Talking Therapies thus far. You have over 1 million people accessing care and seeing improvement rates above 50%. We didn't have time to get into it last session, but you mentioned that you see this moving moving to and potentially above 60%. Based on the clinical outcomes you've seen so far, are you able to share about the planned evolution, next steps, or expansion of NHS Talking Therapies and why you think 60% symptom improvement is attainable?
Yeah. So the first thing to say is that, we had a target of getting people to 50% of people recovering. That was based on the evidence-based randomized controlled trials across lots of different common mental health conditions, which show that on average, around about 50% of people will fully recover from their anxiety and depression with an evidence-based treatment given in a gold standard controlled trial. And around about 70% will show marked improvement. So that seemed an ambitious target for a routine large service. But we've got there now. And when we look at our data, and as you were saying, we're seeing around about 800,000 people a year, and we have a database now of 7 million people who've completed treatment. We can look at that and we can find real clues to the fact that we think we can go further. And the first thing is the dose of therapy that we give. On average in our services, patients have about 8 sessions of therapy. It varies, obviously that's just the average, so it varies from just a couple to over 20. But on that average, we find that if we run our analyses, then actually there's a quite strong relationship between the average number of sessions a service gives and their outcomes. And the optimal value is not where we are now at 8, but it's about 10. So that strongly suggests that if we slightly increase the dose of therapy, we'll do better. But there's another thing that we've noticed, which is to do with what it is that you measure as you go through a course of treatment. And this slide here really shows us this point. So we are always measuring both how anxious people are and how depressed they are. We use the PHQ-9 for depression. And for anxiety, we have a general measure called the GAD-7. And that assesses the extent to which people feel anxious and the extent to which they worry. And what we find is that this is quite sensitive to change across all anxiety disorders. But it does have a problem, and that is it doesn't have the core symptoms of, say, panic disorder. It doesn't measure panic attacks. It doesn't have the core symptoms of social anxiety. It doesn't measure avoidance of social situations. It doesn't have the core symptoms of PTSD, like intrusive memories of bad things that have happened to you. And so we have in general recommended that clinicians also use what we call an anxiety disorder specific measure, one that has those core symptoms in it. But we found that a lot of the services weren't doing that as consistently as we'd like. So recently, we've analyzed the sort of large data set we've got, and we've compared the outcomes in terms of symptoms and disability in patients where the therapist made sure they were giving one of these rather specific measures to help guide therapy, and those where they were just giving the sort of more general anxiety measure. And we statistically controlled for just about every possible confounding variable we could think of. And the results are on the next slide. So here you see on the left-hand side, we've compared the recovery rates using the same metric. So in this case, the general measure of anxiety and the general measure of depression in people who also had a rather specific measure of their PTSD or their social anxiety, their OCD and the panic. And you can see the differences are phenomenal. Although the treatments seem to be largely the same, we're getting much better outcomes when the therapist's behavior is guided by these more specific measures. And you can see for several of the conditions, we're way up in the 60% recovery, whereas it was sort of 45, 50 before. And in PTSD, the difference is really large, from 32% to 53%. So how come? What's the sort of magic that's going on there that these specific measures are producing much better outcomes? Well, you see on the right-hand side of the slide, part of the answer is that actually, if your therapist is using the specific measures, they give you on average somewhat more sessions of therapy, presumably because they're spotting that some of these specific symptoms haven't fully resolved themselves, even if you're saying you're feeling a lot better and you're worrying a lot less. But it isn't just that the dose of therapy is greater. If we statistically control for differences in therapy dose, we still find a big difference in outcome. So basically, every hour of therapy is more effective if it's guided by these more precise measures. So this is why we're pretty confident that we can move the overall outcomes of our services from 50% recovery to 60% or so by increasing the dose and making sure we're measuring the right thing to guide therapy.
Thank you so much, Dr. Clark. For those in the chat, anxiety disorder specific measure is the ADSM. I know I answered in the chat, but just in case anyone wasn't reading that. I think is remarkably exciting. You're almost 15 years in and you've seen remarkable improvement, and I have lots of reason to believe that you can continue on that trajectory. And I think that's promising, especially in a space where we don't usually see that level of improvement, nor can we often even understand the effectiveness due to a lack of useful and actionable data. So extremely exciting. Thank you. In the previous session, you alluded to a fascinating finding that you uncovered through measurement-based care, that mental health treatment can also help improve serious physical health conditions and as a result, save the health system money. A recent article was published in Nature Mental Health this August, and it used data from NHS Talking Therapies to highlight the relationship between positive mental health treatment effectiveness and decreased economic cost. Are you able to share with us your perspective on how improved mental health outcomes can have a positive economic return on investment for healthcare systems?
Yeah, so the target is fairly clear. We know that people with long-term physical health problems like diabetes, cardiovascular disease, chronic obstructive pulmonary disease, the cost of managing those physical health problems is about 50% higher if you have anxiety and depression. So in principle, if you effectively treat the anxiety and depression, you should be able to save money in the rest of your healthcare provision. But, is that principle true? And there's some very nice recent studies in England where we've used data linkage to link up the NHS Talking Therapies data set with other data sets that we have to test that out. And the evidence is pretty strong. So, for example, we have now two studies that have shown that people who've had treatment in NHS Talking Therapies services have a subsequent big reduction in their risk of having outpatient or inpatient hospital admissions for physical health problems. And that's saving about as much money as the mental health treatment costs. There's also a really fascinating study in the European Heart Journal recently, last month or two, which followed people up for 3 years after successful treatment of depression in the NHS Talking Therapy services, and found a significant reduction in future adverse cardiovascular events. And that includes a significant reduction in heart attacks and strokes. So really, the mind and body are closely related. Of course, these are savings in the healthcare bill. Often governments are very interested also in savings to do with welfare benefits and looking at the economy as a whole. And we know that people with anxiety and depression are more likely to be out of work. And when they are in work, they often struggle to stay in work. And there's some very nice data in talking therapy showing that successful treatment can help that. So in the right-hand side of this slide, we have a study where we were developing some new services for people with long-term physical health problems and anxiety and depression, putting the treatments together. And we implemented those services quicker in some areas than others, so we could use the late implementers as the control group. And on the slide, you see the employment rates, pre-treatment of the two groups are no different. If, however, you don't have the combined treatment that we're offering, then you're going to tend to drop out of the labor market. So the employment rate is lower 3 months later. Whereas those people who go into the combined treatment services, their employment rates improve. And these are very big effects. If we could have the next slide, I really just wanted to point out to you that these aren't some sort of quirk of the English system. So Norway has been copying the English NHS Talking Therapies, or we used to call them IAP services. They started their program in 2012. They've got about 60 of these services now. And they've done a couple of really nice studies recently on this. So when they were setting up the latest set of services, a pair of services, they decided to do it as a randomized control trial. So they randomized patients either to usual primary care for their mental health problems, including access to a psychologist or psychiatrist if appropriate, or to joining the IAP type service, which they call prompt mental health care. And they've already published a trial on the clinical outcomes. The recovery rates are about twice as high if you went into the IAP type service than if you stayed in primary care. But more encouragingly, they are now just finishing the write-up of a study, and I was at a conference last week where they were presenting the results, where they have followed patients up for the next 3 years. And what they find is that those people who had the NHS Talking Therapies type service were more likely to be employed and not receiving welfare benefits. And also, and this is something unique that you can do in Norway in terms of where the government provides access to data, the people who were treated in the NHS Talking Therapy services had a higher average income over the next 3 years. So you can do a calculation which economists are very interested in, where you calculate what you call the benefit to cost ratio. So you look at the greater income of the people treated in the talking therapy service versus primary care, normal primary care, and then you divide it by the extra cost of delivering that new service. And you find the benefit to cost ratio is about 3.6. So, you know, if you put in $1 billion on your mental health service, the return to the economy will be $3.6 billion. In other words, effectively treating mental health allows you to grow the economy, something that almost every country in the world is interested in. So perhaps not surprisingly, there are other countries, in addition to Norway, who are following the talking therapy service principle. Australia, Finland, Israel, and the Canadian province of Ontario all have their own versions.
Thank you so much, Dr. Clark. it's been amazing to see, I think, the duplication of what you're trying to do in different settings and unique settings in the
Yeah.
UK across other settings. We're very familiar with the work in Ontario and a couple others that you mentioned. But I think it's all fantastic generally because it creates the conversation like we're having right now, which is one that is based in data and objective outcomes. And I think it's just one that it's been hard to have within the mental health space. And the way in which you've approached this has changed the game completely, both from the conversations that can be had, but also the increase in outcomes that can be achieved because of it. And I think it's also really promising to see the Norway example and see the impact of their service. So in the last session, you briefly commented on NHS Talking Therapies' really impressive completion rate of 99%. And we had a few questions that kind of came up on it, but we didn't have time to dive into it in detail. Can you comment on your overall approach to clinician and client engagement and how you've been able to achieve such an impressive completion rate across the entire program?
Sure. So as you say, we do get outcome data on 99% of everyone who we see at least twice, so the total treated cohort. So what are the sort of things that make that possible? Well, the first thing is to collect very brief measures of anxiety, depression, and disability every time you see a patient. This seems to be important because often people finish therapy at a different time to the time that the therapist might have anticipated. Maybe they got better quicker and then they just don't come back. Maybe they got fed up with you and didn't come back. And so if you just plan to give a measure at the beginning and end of treatment, you often lose the sort of post-treatment data. And sadly, our research shows that when you have missing data, what you tend to miss is the people who didn't do so well. So you're overestimating how effective your service is. So session by session data is important. But then in order to get people to use it, you need to demonstrate its value. So we work quite hard on training all of our therapists in how to use these measures to guide therapy, not just the sort of total score, but looking at the individual items and using that to adjust the therapy. So for example, if you've got a measure of PTSD, that will have items to do with intrusive memories. It will also have items to do with avoidance. Say the total score has gone down. You will then look at, well, yeah, all right, intrusive memories have gone down. Has avoidance gone down or has it gone up? And of course, if intrusive memories have gone down, but the avoidance has gone up, that's not really an improvement, but it also tells you what you need to be focusing on. In fact, that particular avoidance of things which would be a reminder and focus on them more in therapy. And it is important that therapists also look at their data when they have regular supervision. So our supervision system is what we call an outcome-informed supervision. The supervisor and the therapist always have a look at the outcome data for each of the patients they discuss in supervision. Similarly, you know, in order to ensure that patients want to collect the outcome data, they have to see the value. And so we always provide them with graphs of their progress and also, whether there's been a setback. And we ensure that they and their therapist can see them in a therapy session and learn from that. And that, of course, means that the therapist is showing interest in what the patient has done in completing the data. But it is really important that this process of data entry is easy for both patients and therapists. So although we started with pencil and paper questionnaires 15 years ago, we now do the whole thing on a mobile phone where you don't spend any therapy session in inputting the data. Patients all get a short text reminder of their appointments. They click on it, they're into the IT system, and they can just click on some buttons on their screen, on their mobile phone, to indicate how their response to all the different questions in the questionnaires. And that automatically goes into the IT system of the service, and the clinician can just pull it up on their screen at the start of the appointment. We also found that the way you report the outcomes of a service is quite important for encouraging everyone to collect the data. We call this SMART metrics. So say you treated in your service 1,000 patients, and you were just getting going on outcome monitoring. So you managed to get pre and post-treatment scores on 500 of those 1,000. And you looked at that data and you found that 250 of them, they recovered. So you could say, well, our recovery rate is 50%. But that's not what we do in NHS Talking Therapies. Instead, if you treat 1,000 people, you get scores on 500 and 250 recover. We say, and we report publicly, that the recovery rate is 25%. You might say that's a bit unfair because some of the people you don't get data on will have recovered, and we're assuming none of them have. But as a behavioral intervention, it turned out to be phenomenally effective because it meant that in all of our services, all of our clinicians can see there's no value in not collecting the data because we'll just be crediting you with the person not getting better unless you collect the data. And so within about 10 months of starting our new services, we were already up to 90% data completeness. One of our other services, a version of NHS Talking Therapies for children and young people, started 4 or 5 years later. They decided not to use smart metrics in their reporting, and 12 years later, they're still only getting outcome data on 20% of the people they treat. So this does seem to be a really important incentive to get your services to really get behind outcome monitoring.
Thank you so much, Dr. Clark. I think what stands out to me is going back to the beginning of the conversation around process, that if you're going to be doing this and clinicians and clients are used to, let's say, a pre-post model where they've been submitting measurements but not seeing value in it, to loop back with them and make it a process that is then used to inform care and care discussions, you make it valuable for them. And I think doing so, they can start to see why they engage and why they should engage and how it helps them. So thank you so much for sharing that. A quick point, speaking on completed assessments, a number of people submitted a question earlier that they wanted to learn how to best interpret assessment results with clinical relevance and how to best then communicate that with their clients. We won't have time to cover the details of that today. That could be a whole other session, but we will share in the chat a video from one of our previous sessions with the Yale Measurement-Based Care Collaborative, in which they went through an activity called the PHU-9 3-Ways, which is a great training exercise for clinicians and clinical leaders to practice getting curious about results and then communicating them with their clients. So feel free to check that out. This will be the last question we have before we move into audience questions. But we received a few questions during registration regarding the differences in the delivery of care, such as telehealth versus in-person for the NHS Talking Therapies program. So I'm curious if you could speak to any differences you've observed, and if so, what they've been.
Yeah, so this is a really interesting question. And we weren't using a lot of telehealth pre the COVID pandemic, but of course, that forced us to use telehealth. We obviously couldn't see people in person in the clinics. And so we sent our therapists home. We distributed about 4,000 laptops within a week and sent the workforce home to try and deliver the therapy through telehealth. And this was actually a really novel experience for us. We didn't know what was going to happen, but thankfully we're collecting data on everyone. So, it's a natural experiment and we could learn from that. And you can see the data in this slide. So this is 2020. And in England, we locked down in March of 2020. And you can see that as everyone was moving to working from home and getting used to the new laptops and things, there was a slight drop in the recovery rates, not a very large one, and there's a slight drop in the reliable improvement rate. And that persisted for a month. But then we got back to exactly where we were before, and we stayed that way throughout the pandemic. And how did we do that? Well, my research team just gave up doing its normal research for 3 months and spent our time sort of training people in how to do the remote therapy. And giving some tips, like if you've got social anxiety and you're doing the therapy on the internet, then really make sure that the patient's own view is turned off so they don't feel incredibly self-conscious on the video link and then can't concentrate on what you're saying. And we also work quite hard on how you could do treatment of PTSD, dealing with quite emotional topics, but in a manageable way when the person wasn't in the room. And if we go to the next slide, we actually developed an awful lot of guidance in how to do that. And for anyone who's interested in that, we have a free therapist resources website called oxcadatresources.com. You have to register for it, but it's at no cost. Please register as a clinician because you only get all the goodies if you register as a clinician. But you'll find on the COVID-19 page an enormous amount of detail about how to deliver therapy remotely, particularly for the conditions that my research group works on: PTSD, traumatic bereavement, social anxiety, but also for depression. Lots of short video clips in how it's done, and also quite a lot of written guides in how to do it. This is a website that's currently being used in 151 countries. Around about 30,000 therapists log on each day. So you would be joining a worldwide community of people who are working together on this way of relating. But we think this is one of the silver linings of COVID, that we've learned how to do telehealth much more effectively. But we have interviewed quite a lot of patients who were treated during the pandemic with telehealth, and we've sort of asked them, if you came back for therapy again, you've recovered now, but say you had a relapse and you want to come back, would you be happy to have the telehealth again, or would you like face-to-face? And by a small majority, people say, I'd actually like face-to-face this time. So we feel it is very important for services to try and organize themselves so patients have a choice, because there's a lot of research that shows that if you have two different ways of delivering a therapy, which on average are both similarly good, giving people the choice of what they prefer tends to give you the best outcomes.
Thank you so much, Dr. Clark. I think the surge of telehealth during COVID, it's good to see that, one, it's having an impact, that you were able to make that improvement after a slight drop, but two, that the determination that it needs to be a client's choice. I think it makes sense to me. And I also think it makes care much more accessible to people that may not have the time or the ability to travel to an in-person appointment and therefore might not access care. But in this case, they have an option available to them. We are going to.
It can go the other way. I mean, we found some young people, for example, in telehealth. It was pretty difficult because they weren't living in a circumstance where they could have a private room for the telehealth session, or they were in a household where there was some abuse going on, and they really didn't want to be talking about their problems when the potential abuser was still in the household. And so that's why I think choice is really important.
Absolutely. So thank you for sharing all that. Those were the set questions. We're going to move on to audience questions, and we have a good number of them. So I'm going to start with those that are have the most upvotes. So the first is from Mark Grant. Thanks for attending, Mark. And he says, it sounds like having assessments geared to the presenting issues result in the greatest outcomes. So that's going back to our original, what we were talking about off the top. When trying a new assessment to address a specific presenting problem, how much expertise or familiarity does a clinician need to use that assessment effectively?
Yeah, so I mean, we have sort of got a whole series of approved assessment measures for the different clinical conditions, and we sort of set up an expert reference group that looked for each clinical condition and what the measures are that are available in the market and which ones seem to be the best validated. And so we tend to stick to those rather than clinicians having to think of a new measure each time they're treating someone. And we think there's a real value in that, because it does mean you can still, in your service, collect a good cohort of people and see, who's doing well and who's not doing well. And you can also, if you're in a network of services, compare how you're all doing across that network, we often find that, for a particular problem, one bit of the network does rather better than the others, and we pick up the phone and talk to them and try and work out what they're doing. If you want to see what are the measures that we use, there is something called the Improving Access to Psychological Therapies manual, and you can download that from the NHS England website, and you can see what the measures are and what the cutoffs are that we use.
Awesome. Thank you, Dr. Clark. A couple things. One, we put the link to your resource into the chat. So if anyone's looking, because it was on screen, you might not have grabbed it. It is in the chat now, so you can click on it there. I think I'd also just double down on the PHQ-9 three-way activity we had discussed. Grant, Mark, in response to your question, that is the purpose of that activity, is the idea that you don't need to be an expert in order to find value in an assessment, and that just using it and getting curious with it can often get you comfortable and also help the person that you're supporting. So really important that people don't feel like they have to be absolute experts on assessments or on the data side of things in order to find value in measurement-based care. Sorry, go ahead, Dr. Clark.
No, I'm just agreeing with you.
The next question is from William Hudock. How did you establish the metrics of outcomes that you are using, and how are these metrics validated with consumers, providers, and payers? Obviously, this may not be completely relevant in the UK setting, but I'll leave it to you.
Yeah, so I think the first thing to say is that you shouldn't get too obsessed with single metrics. You really get a much better idea of how someone's doing looking across the board at the measures that you take. But the metrics that we use were to some extent driven by politicians. So I think we've thought politicians tend to think in fairly simple terms. You're better or you're not. And so having some binary measure of improvement seemed valuable. And I think at the time we started, a lot of people felt that, once you had a mental health problem, you never really quite got better. And so having a measure of recovery where you drop below the clinical threshold on both anxiety and depression at the end of treatment seemed a very good one to have. It gave hope to people, and it was a good thing to aim for. So that's one of our measures, recovery, and it's just operationalized as going out of the clinical range in both anxiety and depression. Not just for one of them, because we're treating an individual, not just a syndrome. But then the second thing, of course, is showing that even if you don't get to that point, you're showing reliable improvement. So the change is significant and substantial. So that's our other measure, reliable improvement. And those two have served as well. But we also, look at the average score on your measures of anxiety and depression at the beginning and end of treatment, and also change in disability. So one should look in the round, but it is quite good to have a couple of simple metrics. In terms of validation, it turns out that if you do recover, it does have quite profound effects. Firstly, in terms of adverse physical health effects for the next 3 years. In the study I mentioned before, those people who fully recovered have a much bigger reduction in those than people who partially recovered. Also in employment, we find that those people who fully recover have a much higher increase in employment rates compared to those who only partially recover. So I suppose that's part of the validation for it.
Thank you very much, Dr. Clark. Jumping into this next question from Debbie Emberly, who has quite a bit of experience on measurement-based care at a system level. When measurement-based care is focused on the individual patient, using specific personalized measurement tools works well. This is what it is designed for. But there are tensions when we want to use the data for service level outcomes and a tendency towards using the more generic measure. How do you balance that tension?
Yeah, so I hope I've argued that the measures that work best are ones that are still, quite tightly tied to the particular clinical syndrome that you're using. So that's why, we recommend not just the most generic measure of anxiety, but one related to the different anxiety disorders. But of course, we find there are some services who say, well, we'd like to use the data to guide our treatment, but we don't really want our whole service data looked at, and we don't want it to be compared with others. We feel that's more like being judged, and that's an unpleasant process. And whether or not it appears like that, or it's something that people really enjoy, depends on the clinical leadership in the services and on the commissioners of the services. So if the approach to this sort of comparisons across services and things is it simply a sort of bureaucratic one, and people whose services don't do so well just feel like they're being punished or they're being ostracized, then this is not going to work. But if you generate a learning culture where you look at, oh, it's really interesting to find out the areas where we're not doing so well, because that's where we can innovate. And then you bring the whole team together in discussions about that innovation, and without any sort of punitive element to it, then you really generate vision and you generate excitement in the whole team, and it pulls people together as innovators. So I think that's the main difference that we find. You have to have commissioners and clinical leaders who are viewing the data as sources of excitement and wonderment, and using it to move things forward, pulling the whole team with them.
Thanks, Dr. Clark. I think that was one thing that stood out to me from the last session as well, of we're going to inevitably have clinicians that push back against measurement-based care for many of the reasons you've already mentioned. But you had said on the last call that, like, first of all, starting with sharing with them how to understand, sharing with them how the process will work, what the data is going to be used for, and how we're going to dive into it is one way to start to get people on side. But I think you had shared that when they really get on side is that you don't just say it, but you actually show it. And now they see us diving into the data together collaboratively and making decisions for treatment. And that's where there's a little bit of a light bulb that turns on. It's like, oh, I don't have to have my backup. This is going to be used in a very positive way for us overall. So I think that really stood out to me.
I should also mention that I talked about commissioners and service leaders. I should also say about supervisors. In general, in psychological therapy, we would recommend that everyone has a chance to have some regular supervision. And again, if the supervisor and the clinician are looking at the measures together, and the supervisor again instills this interest and wonderment from the measurement, that really pulls someone along, because they feel, oh, yeah, I'm learning some extra things that I can try out in the next session, and then, report back to my supervisor from this data. And, we'll find out whether the hypothesis we generate is making sense or not. You're on a sort of journey of wonderment then.
Curiosity is contagious, hopefully. I think this is going to be the last question of the attendee submitted questions before we wrap up. But this is an interesting one. And the person, Stacey McNeil, has said Greenspace, but I'm going to replace Greenspace with measurement-based care and get your perspective on it. Can you please speak to using measurement-based care in work with couples, individual PHQ-9, GAD as an example, and how those are discussed or used in the therapeutic space within couple work, or how they might be discussed or used in the therapeutic space within couple work?
Yeah, so this is a really interesting question, actually. We tend to see quite a lot of people in whom one member of the couple is depressed, and there's good reason to suppose that some of the issues in the relationship are partly contributing to that or maintaining it. But thankfully, the person's partner is willing to come in and join the therapy and work together with the client. So then we do tend to give the PHQ and the GAD to both members of the couple, but we're mainly tracking, what's happening with the target patient. But with the couple seeing the fluctuations for both of them, it can start some really interesting conversations. The partner can discover a bit more about the things that are happening, which are really pushing the patient down in mood or up in mood in a way that they maybe wouldn't have observed directly themselves. But also, the sort of target patient can get a better understanding of some of the difficulties that their partner is going through. And so it becomes a bit of a opportunity for discovery about things that are going on in the relationship that you wouldn't have noticed otherwise. But of course, as always in couples therapy, these things need to be dealt with in a sensitive way.
Thank you, Dr. Clark. There are two questions that I would love to get to, but we don't have time for both. That's for sure. I know I said that was last, but I think you might be able to answer one maybe relatively quickly. One is around for payers incorporating measurement-based care into their work. I don't think we have time for that one, but I think, Dr. Clark, we would definitely be happy to talk about that afterwards. There's lots of payers that are trying to work collaborative with clinics, clinical leadership, to make it work in the right way for them as well. And I think that collaborative approach has been really important for in the discussions we've been having, but happy to expand on that offline. Just wanted to see if you had time to answer this one. Does measurement-based care work for seriously mental ill populations? Example, schizophrenia, severe bipolar disorder.
Yes, great question. And the answer is yes. So we have in England a quite large program on early intervention in psychosis. So people who've had their first or second psychotic episode, and we bring them into a system of care where we give them, we really try and adjust them to give them optimal medication, but we'll often give them CBT for their for the psychosis, also some family therapy if that's appropriate. And we are tracking how they're progressing in that regularly with outcome measurement. And we do find that really informs the sort of package of care that we give them. And because that's been so successful, we have recently decided as a nation that we're going to bring outcome monitoring into the whole of our community mental health care system as well.
Well, that's fantastic news. Thank you, Dr. Clark. So this is the last question before we wrap up, but after leading NHS Talking Therapies for over 12 years now, can you share with us the biggest lesson you've learned through your experience that you'd like to pass on to other behavioral health or system leaders that may be in attendance?
I think the biggest lesson is the value of outcome monitoring, to be honest. We put a lot of work into developing a system where we gave the evidence-based treatments and we trained people well to give them. But I think, as you mentioned at the start, the outcomes were not as good as we were anticipating initially. And we could have been just very disappointed by that. But the data allowed us to learn so much and to improve. And the way we deliver the therapy now is different from the way we would have guessed. And it's a bit different from what the randomized controlled trials would tell you, because, we've figured out little tweaks to the system that work better for those people who, for one reason or another, haven't been doing so well in the first place. So you're just learning new things all the time, and it just makes it so much more exciting to be in those services. Recently we did an analysis of a large data set, and we found there's a subset of people who don't have any particular diagnosis, but have a number of personal characteristics that seem to cluster together, and they have, on average, pretty poor outcomes, about 20% recovery. But once we'd spotted those people, we could then run the algorithms which identify them when people come into the services at the beginning. And people in about 4 or 5 services got together and thought, what can we offer them which might be a little different, that might be addressing this sort of intersection of problems they have? And having done that, we've more or less doubled the recovery rates of those people. This is just something you can't get at without having this sort of data, and it makes it so interesting.
Thank you so much for that. I think it's obviously a sentiment we echo in every way, and I think it's what's exciting as well when you share all the different countries that have been trying to replicate what you're doing in the UK in different settings. It's amazing to see that momentum, as well as just small clinics, large clinics, systems really start to take it up. So I think it's an exciting next 5 or so years for.
I think maybe I should say the last point about it is that it also releases much more money for mental health. So the NHS Talking Therapies program, it was started with a government on the left of our political spectrum, the Labour government. We now have one, much more on the right, the Conservatives. We've swung from left to right in the 15 years of the program, but every single administration has increased the funding of this program. Pretty unique. Normally, new administration wants to do its own thing, closes down much of the stuff that the previous administration's done. But this has not happened with NHS Talking Therapies. And I think it's because all the politicians can see, wow, it's worth investing. People are improving and it keeps on doing better. So it doesn't really matter what your political persuasion is. You put in extra money in mental health. So that's been the big thing. So the amount of money we spend on mental health treatments in England has really gone up as a consequence of this.
Data is powerful, and I think it's hard to argue with it. And that's the change that you've been leading. So a massive thank you to everyone that attended. To learn more about NHS Talking Therapies, the impact of measurement-based care, and general approach and insights to implementation, I'd also like to take a moment to express my and our sincere gratitude, Dr. Clark, for the work you do every day to champion innovation in mental health care. We're always following along with your work and are so thankful for your trailblazing, but as well, thank you for joining us on the webinars and sharing your immense knowledge surrounding measurement-based care.
Well, thank you for inviting me. It's been lovely to join you all today.
Awesome. Thank you. If anyone's interested in exploring measurement-based care implementation, please reach out anytime. As well, Greenspace will continue to host measurement-based care educational sessions with experts of all different backgrounds. So please stay tuned for our next session. And one last thank you to each of you for attending, and to Dr. Clark for your generosity of time and the incredible insights you shared. Have a great day, everybody, and thank you.
Take care.